So in this talk, I want to talk about pediatric hemorrhagic shock in trauma. I'm going to talk about how to recognize shock. We're going to talk about having a structured approach to the management of shock. And then we're going to talk about massive hemorrhage protocols, what they look like, what are the core components, and how to do them well. So before we can manage shock, obviously we've got to recognize that it exists. And fortunately, hemorrhagic shock looks in many ways much like other types of pediatric shock. So if we have a flat child that's making poor eye contact or interacting poorly with their parents, with a prolonged central cap refill or low blood pressure, if they're tachycardic, pale, clammy, etc., then that is the type of kid who's going to be likely shocked. One thing in particular to think about in pediatric shock is that hypotension is a very late sign, and that is different, and how we approach hypotension in kids in trauma is different than how we approach hypotension in adults in trauma. And that's because in adults, we have that philosophy of permissive hypotension in order to minimize fluid administration. And in kids, unfortunately, hypotension is such a late sign that it's actually more of a clear warning tool that this kid is extremely unwell and needs aggressive resuscitation. When it comes to actually thinking about managing hemorrhagic shock, that can be pretty overwhelming because we don't often see that in kids. This is a rare thing in our society. And so it can be quite overwhelming. But actually, this complex thing really boils down to two key goals. We want to plug the hole. Whatever is bleeding, we want to plug it up and stop it bleeding. And then the second goal is for us to fill the vasculature to the point where we restore circulation and mitigate shock. And apart from getting that patient to their definitive destination and care, that's really all we can do in emergency. So it's actually not too complicated. What we've got to do first, though, is actually find where the bleeding is coming from. I'm going to do a thorough primary and secondary survey, and hopefully between that and some x-rays, we might start having a general idea about where that internal bleeding could be if it's happening. If it's external and we can see that on our primary survey, then great, we can intervene with direct pressure. But often we're concerned that there's bleeding going internally instead. So we've got a few tools, don't we? We've got our ultrasound, we've got CT, and we've got MRI. And what I would basically say is most of the time in serious trauma, CT is going to be our go-to in pediatrics. And that's very different to how we might think about CT normally in kids. So we're particularly very nervous about giving CT abdomens and CT chests if we don't have to. But if we've got a serious trauma mechanism, then that is going to be the investigation of choice most of the time to definitively guide us about what's happening inside that abdomen. Ultrasound does have a role, but it is much more minimal than in adults. And the reason for that is specifically to do with fast scans. So in adults, in traditional adult trauma teaching, if you have a hemodynamically unstable patient and they have a positive fast scan that shows blood in the belly, that essentially means that patient needs to go straight up to theatre, not muck around, not go to CT, and instead have an exploratory laparotomy to just get on control of that bleeding. In kids, however, actually most injuries, even when they're surprisingly severe, actually can be managed conservatively. And so they're much less likely to go to theatre, even if there's blood in the belly. So a positive fast scan doesn't answer the same binary question that we need answered in adults, i.e. do I need to go to theatre? So in children, the vast majority of solid organ injuries are managed conservatively. And so most of the time we're going to need to do a CT. MRI would be nice sometimes, but from a time and availability perspective, it's often not pragmatic. So once we've identified the source of bleeding, we need to make it stop. And that is how we do that is going to depend on the injury, obviously. But essentially, we've got these three main options. So if we have a fracture that is causing bleeding, so say we're bleeding into a long bone, then fracture reduction is going to be the key tool to minimize bleeding and stabilize that hemorrhagic shock. So we might have to reduce the fracture, we might put on femoral traction splints or pelvic binders to try and decrease the amount of blood that's being lost into that space. If we can see external bleeding in particular from a clear source or an arterial or venous bleed, then we're going to apply pressure. That's going to be the main thing we can do in ED. And so this acronym of DDIT can be useful in thinking about ways to scale up our pressure during trauma. So we're going to apply direct pressure first to the wound. Then if that's not working, we're going to apply even more pressure. One thing to note about direct pressure is that because pressure is inversely proportional to diameter, if we actually press down with a hand, for example, versus a finger over the point, then actually, even though it might feel like we're applying more pressure, we're applying less force to the location that we need. So we want to use the minimal diameter possible to apply the maximum pressure to that location. If that's not working, we then want to think about indirect pressure, i.e. pressure to the arterial supply that is proximal to the source of the bleeding. And then lastly, we can think about tourniquet. And tourniquets are less used in a hospital setting, certainly used in a pre-hospital setting, but may be used sometimes. And apart from that, besides trying to get the patient in a good position, trying to apply decent pressure, the other thing we need to do is if we are stopping the bleeding, we want to help that clot stick. And so that includes thinking about how we're going to do that. So we might use hemostatic dressings. We might use adrenaline-soaked gauze or tranexamic-soaked gauze. We will give tranexamic acid in a trauma setting. So tranexamic acid's dose is exactly the same as paracetamol, so it's easy to remember. It's 15 milligrams per kilo. And you have an IV push, which can be given stat, and then you give the same dose over 6 to 8 hours. If we can't stop it, then A, we need to start our massive hemorrhage protocol, but secondly, we need to think about definitive management, and that's when we might need to activate a red blanket. So a red blanket is a protocol that exists in some hospitals, not all of them, that essentially flags that there is no benefit for the patient to continue to try to resuscitate in the emergency room, and that the only way, or the most likely way, that that patient is going to be saved is to get them to theatre as fast as possible and to stop mucking around in the meantime. So the red blanket is essentially, metaphorically at least, applied as sort of a clear signal for everyone to get hands off the patient and to do absolutely nothing to delay their transfer to theatre and smooth that out as swiftly and as safely as possible. So it's an acknowledgement that sometimes we can get stuck in a circle of resuscitation in emergency that's not actually getting the patient where they need to go. And that could lead to them deteriorating because we've delayed them getting to definitive management, trying to improve things when actually we just need to get them to theatre. So we need to also think about how to activate a massive hemorrhage protocol and why we would do so. And so if we think about our protocol within the hospital that you work with, there are a variety of different triggers, but the traditional one would be in children. If you are thinking you're going to need or have given more than 40 milliliters per kilo of blood or fluid, if you are anticipating a transfusion of greater than 50% total blood volume in 3 hours, or a transfusion of greater than 100% total blood volume in 24 hours. So just to repeat that, massive transfusion in kids designed as needing or anticipating more than 40 mils per kilo of blood during resuscitation. And to be honest, Blood Bank would prefer that we activate this early and then switch it off if it's not needed, because all those blood products take time to thaw and prepare. And so activating it either last minute or too late can be really, really hard on them and detrimental to the patient. One thing to think about though is what does 40 milliliters per kilo actually look like? Because we will be visually looking at blood and blood loss during a trauma resuscitation. And so actually one scary thing is that for a small child, and particularly for a baby, 40 mils per kilo isn't actually much fluid at all. So a bluey can absorb around 120 mils of fluid. And so 200 mils, which is 40 mils per kilo in a 5 kilo baby, that's essentially a coffee cup. So it can be unappreciated, particularly if we've got big, strong pressure dressings on that are absorbing a fair amount. We can underestimate just how much proportionally a child has lost during a trauma. So this takes us to the massive hemorrhage protocol. I don't know about you, but I find massive hemorrhage protocols quite confusing, overwhelming. And the reality is from the statistics that actually this is hard for emergency departments to get good at in peds because it is just so rare, even in tertiary pediatric settings, that we don't get the chance to meaningfully practice this. And so that means we've got to get good some other way. And part of that, I think, is getting good algorithms. Part of that is understanding the concepts as best we can before we have to go in and resuscitate. And part of it is building systems that make it as easy as possible for us to administer an MHP. But the goal of this slide really is to try and demystify, if you're new to massive hemorrhage protocols, what they are, because you might have seen different protocols around different sites. And they all vary. They're often quite complex to look at. But these are the main goals. It's not that complicated. So you're going to activate a massive hemorrhage protocol by calling blood bank usually. You're going to give tranexamic acid in trauma because that has evidence of benefit, and we're going to give that straight up stat at 15 milligrams per kilo, and then that second infusion starts running. We're going to resuscitate if they're shocked with saline if we have it. Saline until we have blood available. And as soon as we have blood available in trauma, we're going to switch across to blood. We're going to essentially resuscitate with red cells for volume, i.e. treating the shock and the hypotension. And we're going to additionally give blood products to help that blood to continue to clot appropriately. And then we're going to take tests that tell us how the blood is clotting. We're going to respond to those tests. And then we're going to keep giving red cells for volume and products for clotting over and over and over until we get to definitive management or the patient dies. And that's a massive hemorrhage protocol. So when we think about giving volume, obviously our core goal is that we're giving red cells in trauma as much as possible. So there's a move in evidence-based trauma care over the last few decades towards a principle called damage control resuscitation. And essentially what that means is in adults, we're focusing less on achieving normal values, particularly blood pressure, and instead concentrating on resuscitating with blood and blood products more early, and aiming to preserve the clots that are made by avoiding that diamond of death, which we'll talk about in a few slides. So we have got good evidence from adult trauma and military studies on the benefits of resuscitating with blood products rather than crystalloid fluids. But one thing we can't do in pediatrics, as I've emphasized, is pursue that concept of permissive hypotension. That's because in kids, it's a really late sign. There are some advocates when we talk to surgeons, though, however, for this to be adapted to a concept of permissive tachycardia, i.e. we'll tolerate tachycardia. We won't try and get that fully down to normal, but we don't want to tolerate hypotension like we would in adults. The dose is the same, right? 10 to 20 mils per kilo, and reassess your patient. While we're giving volume with red cells, we want to support the blood's clotting pathways to ensure that we're as likely as possible to stop bleeding out. So doses of this will vary somewhat between protocols and hospitals, but this is a pretty decent guide. And basically the goal here is to give either products that are needed in the clotting cascade or substrates that are used in those chemical processes. And TXA to stop the clot. So tranexamic acid is an antifibrinolytic drug that prevents breakdown of a formed clot, and the dose is 15 milligrams per kilo. Fresh frozen plasma contains clotting factors needed for the clotting cascade, and the dose is 15 milliliters per kilo. Platelets obviously form the clots that we want to make, and so they get used up in hemorrhage. And a standard volume for infusion is 15 milliliters per kilo. And then you need either cryoprecipitate or fibrinogen, and that'll kind of depend on which hospital you're at and what availability you have. And the goal here is to top up fibrinogen. And so that's an essential substrate for clotting. And we're going to give cryo at 5 milliliters per kilo, or fibrinogen at 50 milligrams per kilo. And then lastly, we want to give calcium if the calcium is getting low. And that's because hypocalcemia is an independent measure that's associated with increased mortality and morbidity in trauma. And it goes low during during massive transfusions. So in response to low calcium on the gas, we're going to infuse one of two things. If we have a central line or an IO, we can give calcium chloride at 0.2 milliliters per kilo. If we have a peripheral IV, we're going to give calcium gluconate, 0.5 milliliters per kilo. So probably for me, most of the time, we're going to end up starting with calcium gluconate through a peripheral IV line. The challenge with this is we're running through our massive hemorrhage protocol, is that some of the things we are doing and some of the things that are happening inside the patient are contributing to these four things that constitute the diamond of death. And the challenge with these is that these all make your patient sicker and make it harder for the blood to clot. And so they can become a very vicious cycle that's very hard to stop. So we want to stop our patients getting cold because that makes it harder for our blood to clot. So we're going to actively warm fluid and we're going to warm our patient. And sometimes we'll warm the room. We want to prevent acidosis. And if you actually run a blood gas off a bag of red cells, it's pretty scarily acidotic. So we don't treat bicarb to mitigate acidosis because we don't have evidence for that being of benefit, but we want to help the body clear that acidosis by making sure we've got good oxygenation and good perfusion so that it can clear it itself. We want to mitigate coagulopathy by giving the blood products that we described, and we want to minimize hypocalcemia by giving calcium. And that's how we try and avoid the diamond of death. When it comes to massive hemorrhage protocol, one thing you might have heard is this idea that there is a ROTEM or TEG guided pathway and a standard one. And so the metaphor that we've got here to try and explain that is that a massive hemorrhage protocol following a standard algorithm is essentially a recipe. So you can follow that recipe and you'll get hopefully a pretty good result, a pretty good makeup of what resuscitating with whole blood would be. A ROTEM or a TEG is essentially more like taste testing, like a master chef might do. So we're going to instead give red cells for volume, and then we're going to test the blood's ability to clot using the ROTEM or TEG tests, get live updates on an app, hopefully on our resus screens, and then we're going to curate and titrate the products that we're going to give based on how that blood is clotting in real time. Now, it sounds really cool, but I think it is really important to think about the human factor complexity that adds without a huge amount of benefit in pediatric trauma or that has been seen in evidence. But at the end of the day, I really want to demystify the difference between standard and ROTEM and TEG guided algorithms because they're still basically the same. At the end of the day, we're still giving tranexamic acid. We're still resuscitating with saline until we have blood. And then, once we've got our massive hemorrhage protocol packs, we're going to essentially still be giving red cells for volume and products for clotting. The difference is, in a standard algorithm, the products and the blood are kind of mixed together in each pack with a recipe that hopefully is reasonable enough to work. Whereas in a ROTEM or TEG guided, we're mostly giving red cells for volume consciously, and then we're going to deliberately choose what products we're giving to help the clot formation using an algorithm or a guide or our understanding of the ROTEM and TEG tests. And then we're going to continue to do tests, check how the blood's clotting, and continuing around that cycle of giving more blood, more red cells for volume, more products for clotting. So it's not that different. There are a few things to think about specifically if you're using a ROTEM or TEG guided pathway. So in Prince Charles, we do have a ROTEM machine. We need to think about where that machine is. So is it in blood bank? Is it in theatre? Is it in ICU? Because the runner for your team will need to know this, as they may be taking pathology tubes to multiple sites. They might be going to blood bank and ICU, for example. Another thing to know is that ROTM actually takes about 30 minutes to complete. So if you have a live update app on your resus screen, that's great. You can kind of watch it and react to the initial results. But if you're sending a runner somewhere to get you the result and then come back with it, you might not have data for about 40 minutes. And the final step in ROTM and TEG tests is clot degradation. So it is always going to take at least 30 minutes for that test to come back. Thirdly, you need to think about who's going to actually interpret that test. And I would argue that if we have good systems in place, you should be able to follow an algorithm without really knowing anything about ROTM at all. But it can be really overwhelming. So knowing where is your expertise and who's going to guide you through that. And then we'll see how we go. This is an example of part of a ROTM guided MHP algorithm. I'm just putting this up so that you have a basic picture in your head of what that looks like rather than trying to teach you the whole algorithm. So you can see as the blood is clotting or not clotting, in this case, it's forming an image on the screen, but you actually can ignore that and you just look at these numbers. So we've tried to make this as simple as possible. If the FibTem CT is greater than 300 seconds and the XTem A5 is less than or equal to 35 millimeters, give tranexamic acid plus cryo or fibrinogen concentrate. And once you've given product, you should repeat the ROTM 10 minutes after that and restart. And that's basically a ROTM. And this is just an example of further down the pathway. So look, the idea of an MHP, hopefully now that we've kind of broken it down, is actually pretty simple. Give tranexamic acid, give red cells for volume, give products for clotting, and test how that's going. But the challenge is that the execution of this task is actually incredibly complicated, and there are a lot of moving parts. In addition to our usual resus roles, we need to adapt our team structure to match the needs of an MHP, because our traditional trauma roles of airway, circulation, drug, team lead, and scribe, for example, don't actually fully match the needs of the task in front of us. So here are some roles that I think we should really think about and embed. And one at Prince Charles in particular is assigning a blood bank liaison doctor to literally stay on the phone with blood bank the entire time that MHP is running. And the reason for this is very simple. A, it gives us good information from the experts and we can update each other on how the patient's going and any problems we're having that allows us to problem solve unexpected things. Secondly, usually in most hospitals, the person who activates the MHP is often the consultant or the team leader. So they call blood bank, they activate the MHP, and then they hang up and they start ringing everyone else in the hospital. And then blood bank keeps trying to ring them to let them know something important, and they're on the phone to somebody else, which can be a real safety issue. We need runners, and we need to think about who makes the best runner for this task. And that means somebody who knows all of the places outside emergency, who can get swiftly to blood bank and to wherever your ROTM is. And so that's often a wardie. And in some hospitals, they've said, oh no, this is so important, we want a nurse to do it. But actually thinking about, does your nurse who works in your department know their way around the hospital to those less frequently visited places as well as the wardie did? And I'd argue almost always no. We want to assign staff members, usually nurses, to actively checking the blood products that arrive and administering that as rapidly and safely as possible. And that often takes more nurses than is initially estimated. We want to make sure somebody is signing the pathology correctly, and this is really, really important because often when we simulate this and in our real MHPs, getting the damn blood tubes signed correctly the first time is often very, very hard to do. So making sure that's checked, triple checked, and then sent can prevent a lot of heartache when there's a big delay in that first MHP pack arriving due to incorrectly signed samples. We also want to think about escalation and transfer. So who is the right person right now to be advocating for this patient's either escalation to theatre or transfer to another facility? And sometimes that should be the team leader, but sometimes that team leader has to be coordinating all this other stuff, and it needs to be somebody else with enough expertise and knowledge to advocate appropriately for the patient. While we're running this MHP, we're going to have to keep testing. And that's going to be a little bit different whether we're using a standard algorithm or ROTEM and TEG. So as I mentioned in ROTEM and TEG, essentially after every 20 milliliters per kilo of red cells or after blood products have been given, we're going to test after that about 10 minutes afterwards. In a standard algorithm, there are less guidelines about when that should be. It should be at least hourly, but we don't fully know. And I'd argue we can be doing blood gases at least much more frequently than that. We're going to manage the temperature control to prevent hypothermia, as we mentioned. And that's actually uncommon in Queensland, but that means we don't practice it very well. So a hypothermic patient who has an increase in core temperature of 1 degree is associated with having 10% less red cells needing to be transfused. And in addition to this, hypothermia is an independent predictor of mortality. It increases blood loss and and causes higher transfusion requirements. And cold blood products can really worsen hypothermia. So we want to think about monitoring our temperature, which means tympanic until we've got central monitoring. We want to be looking at that about every 15 minutes, especially if we're rewarming. We want to maintain their temperature by preventing heat loss, by using passive rewarming like removing wet clothes, improving the room temperature, getting warm blankets and a head wrap, giving blood through a fluid warmer at 41.5 degrees, and sometimes even giving warm inhaled gases and using a heat and moisture exchange filter. The last thing we want to do is remember to actually terminate the protocol. And this is really important and also something we do poorly a lot of the time. And this is really upsetting for blood bank because they are still preparing, thawing, and sending down blood products for use. And it can often be forgotten in the heat of the moment that those blood products are still coming. And if we identify that we've terminated the protocol, tell blood bank and get the blood products that haven't been used yet back to blood bank, they can often be saved. So just to recap, because we've covered a lot, we've wanted to learn how to recognize shock in the injured or the trauma patient in kids. We've talked about how a basic structure for resuscitation is essentially two things: plug the holes and fill with volume. And then thirdly, we've talked about massive hemorrhage protocols and identified that they're not that complicated, that they're essentially activating, giving tranexamic acid, resuscitating with saline until you have blood, resuscitating with blood until you have the first pack, and then moving through red cells for volume, blood products for clotting, and responding to tests and then deactivating. And above all, thinking about what is the disposition for this patient, what is their definitive management, and how are we going to get them there. I hope you found this useful, which is really useful. Uh-oh.